but over the last few months of being involved with this, I actually feel like it's feasible, it's possible, and bringing everyone together in this community is just so inspiring, actually, to hear about the ways we can get out of technology and science and what we know about prevention and how we can engage all aspects of the healthcare system, from, like Bob Kaplan has mentioned in the past, the young youth and the targeting before people are sick, up to the care systems and technology, like we're going to hear about from Tatyana today. So I think, Hattie, we can get started. You'll make some remarks.
Well, I was reminded by one of our guests that this is the 4th meeting of our 4th University Best Practices that we've started regionally. All 4 are going strong, and we're just so happy to see all of you. And please don't be shy. Come on up to the table. We have a couple spots at the table, and we may have some people come in late, but they can sit in the back row. Anyway, thanks for being here. We have the wonderful opportunity to hear from 2 brilliant immigrants. One who just became a U.S. citizen this year, Dr. Eveline Stock, who is our metabolic cardiologist from UCSF, and Tatyana Kanzaveli, who I learned was actually a refugee from the USSR. Not only was she chess champion and on Gary Kasparov's team, she has really overcome so much to be with us today, and just so thrilled to have this incredible group of people coming from the 4 winds to really push the get towards zero equation to apply the science that we have that we're not using to prevent preventable heart attacks and strokes and reduce disability and death. And thank you for flying up from Los Angeles for this meeting, the Trines. They've been long-time RightCare enthusiasts and help us across the state. So bless you for being here. And thank you to the new faces in the room. And with that, I'll hand it back to our chairperson.
Thank you. Okay, I think, we do have a few new faces, and so maybe we could just briefly go around the room and say your name and one thing that you are excited about by being here at the RightCare Initiative, for those of you that are familiar with it. But we'll have to keep it really brief, okay, you guys, so that we can get started with Eveline's talk. So you guys have heard me talk a lot, so I'm just going to pass that on.
I'm Bob Kaplan. I'm a faculty member of the Clinical Excellence Research Center here at Stanford, and it's just always fun to be here.
Hi, my name is Rhonda McClinton Brown. I am the branch director of the Healthy Communities branch of Santa Clara Public Health Department, and transitioning out of Stanford at the same time, where I've been for the last 11 years as the executive director of the Office of Community Engagement. So I'm happy to be here.
Thank you. I'm Chavi Mehta. I'm an internist and I'm the Associate Medical Director of Quality at Palo Alto Medical Foundation. And I'm so happy to be here and meet all these talented people in the room. Thank you.
Hi everyone, I'm Victoria Dupuis, founder of No More Broken Hearts. I've been coming to RightCare for probably about 2 years now, and it's always great to come together with great minds, big hearts, and just a ton of passion for wanting to save lives. So thank you for letting me be here.
Hello everyone, Jim Drury. I'm CEO of Life Saving Images. Second time here, so this is great to be here again. We build mobile clinics, so we're a proponent of early detection of a number of things. We have a calcium scoring mobile clinic that's now working just in the final stages of going live, among other things.
Hi, I'm Kiran Mehta. I work for MapR Technologies. I'm the Vice President for Innovation at that company, and what we focus on is building technology that enables you to process petabytes of data, run different kinds of AI ML algorithms. So I'm here to see what are the kind of use cases that exist in healthcare and how data and analytics can help improve patients' lives.
So Bob Trine, I've had the pleasure of working with Hattie for the last 4 years or so. I'm the CEO of Trinomics, which is a polygenic risk scoring startup. And my passion, I guess, is to try to rebalance the amount of effort that's spent and the dollars that are spent. If you think that $2.5 trillion are spent treating preventable chronic disease, and 2% is spent on the front end of diagnosis. So I'm interested in anything that we can do to try to shift that balance.
Hi, I'm Lynn Trine with Trinomics, and for me, coming for the last, 2-3 years, it's always an inspiration and a wonderful learning atmosphere for me in all of this. I'm very proud of all of you.
There we go, and on.
Hi, I'm Anthony Cordova. I work with Jim at Life Saving Images. I'm the EVP of Business Development and Strategic Partnerships. This is my first time here, and I had my own heart issues a couple years ago, so this is more than a job to me right now. It's a career and a mission these days.
Hi, I'm Claudine Wu. I'm a visiting research scholar with UC Berkeley School of Public Health. Very happy to be here with Hattie, supporting the group.
And I would just encourage the two of you to come on up to the table. There are a couple seats here. We'd rather have you close in.
Good evening, everyone. I'm Lorianne DiMartini. I'm the CEO of the California Society of Health System Pharmacists, also a pharmacist. I was with the California Department of Public Health for 30 years, and I'm all about prevention. And so I'm thrilled, and I've been part of Hattie's group in Sacramento. I'm thrilled that there's this collective intellect and expertise and enthusiasm and passion to get us to zero. I lost all of my grandparents, my father and my mother, to cardiovascular disease, so I'm all in.
Hello, Lila DeBaptiste with Johnson & Johnson. Jeannie usually is here, and I am very pleased to be here in her stead this evening. Johnson & Johnson has been a huge supporter of the effort, and just excited to hear what we're doing and how we can continue to support.
Thank you.
Catherine Benton with Personalized Nutrition Solutions. I'm a nutritionist, and I specialize in working with clients that have autoimmune diseases and hormonal imbalances, and they normally call me after you give them the bad news. So that's how I fit in the group.
Hi, my name is Ashok Krishnaswamy. This is the second time that I've actually been here, and it's a wonderful group. My interest in this is it really, as a geriatric sensitive cardiologist, my focus is really multimorbidity and chronic conditions, and so I hope to learn something here, and it's a wonderful group.
I'm Joe Skye. I'm Chief of Cardiology at Travis Air Force Base, and I love coming to the RightCare initiative to see the different perspectives and learn together.
Okay. It's the same time.
Hi everyone, my name is Leron Krehler. I'm a stroke fellow. I work with Dr. Mora. I'm very excited by the tagline. This is my first meeting here. I'm all in. I'm invested in everything preventative from heart health and stroke prevention. So this is very exciting for me. Thanks for having me.
My name is Rick Rielson. I'm a pharmacist, and I've been in the pharmaceutical industry since 1986, working in preventive medicine, hypertension, heart failure, dyslipidemia, diabetes, obesity, which drives a lot of this, and a few other areas. But I'm pleased to be here. I was lucky enough to have been born with LDL receptor problems, so I have FH. I found out at 25 that I had LDL of around 250, and the statins were not on the market yet. So it's very interesting to me. This is a very good area. Thank you very much.
We're happy that you're here in many ways.
Yes.
My name is Matthew Polomic. This is my second time here. I'm a retired nuclear engineer, but as this gentleman said, I have my own heart issues, and I have a lot of questions. And being a guy who likes math and statistics and probability, I want to hear it all. So thank you, Hattie, for inviting me, and it's a pleasure to be here.
Hi, I'm Jeff Boyd. This is my first meeting. I work for the Santa Clara County Public Health Department. I work with Rhonda on the Diabetes Prevention Initiative. and have had some conversation with people who are in the back collaborating, so we're really happy to be here.
All right, thanks everyone for being here. It sounds like we're all in, and we have all of our reasons for being here. So Dr. Stock, my co-chair, is going to be talking today about updates in genetics and metabolism with cardiovascular disease. And it may relate to many of you who have familial disorders, but also can apply to our general practice. So she's going to start us off, and then we'll go from there.
Moving a little slow these days. Thank you for being here. And my goal today, as I was putting together this talk, I think my main goal is to give you a sense of where we are and where we can go regarding cardiometabolic risk. This, to me, is the most important data point, or data points that we can acquire. The idea behind having this be a technology-driven group is that we want to take data and make it effective, use it. And I was hearing the story in NPR last night about how all these data gathering corporations are using data to change our behavior, right? Voting, buying clothes. Why can't we do it for healthcare? So I put that out to you as I begin this talk. So I am going to try to show you some mechanistic approaches to management. If you understand the mechanisms, you'll probably understand how to best treat your patients. So that, so I found this quote in one of the societies that is trying to promote our guidelines. So they're paving the road ahead, new clinical guidelines. Knowing is not enough, we must apply. Willing is not enough, we must do. And that sounds like a little bit like Yoda. How would you design trustworthy guidelines? So that was something that I was saying. We always complain about the guidelines, right? We're always thinking that they could be better. I think that this year, in 2018, the societies did a pretty good job. And I'm happy about that. And how would we design these? We need to advise clinicians, advise healthcare systems, and also the insurers. And it's very hard to think about one size fits all, right? So they must be concise. We're not going to read 300 pages of guidelines. They must be clear so that we can understand. Evidence-based, very important. Flexible, because our patients are not all the same. They must be as well universal, that we can use them everywhere, at least in the United States, right? And we're a pretty diverse community. And try to provide best advice for the greatest number of patients, but then it must be personalized at the same time. We're coming to an era where we need to be personalized and give each patient what they need so that they can lead a healthy life and get to zero somehow. So these are the guidelines. I think most of you must be familiar with them, but
I think
just
a summary, right, of the guidelines are on the back of the bio page. Yeah. So please keep these and put them in your wallet.
yes, please. And we're going to talk a little bit about a couple of those take-home messages, okay? So these guidelines, what was great about them is that the American Heart Association and the American College of Cardiology didn't take this upon themselves. They enlisted 10 other stakeholder organizations, including the National Lipid Association. They wanted to ensure best practices, create consensus, and promote distribution. So that is very important. You know, the merits and shortcomings and what I think is good or bad is out of the scope of this meeting, but you know, we'll have time for that down the road. Takeaways, I try to summarize what I took away. They synthesized the guidelines to those 10 beautiful take-home messages that Patty was referring to, and they also created this hub of related resources for clinicians and patients. I don't know if you've seen that one. Maybe Brian will have to help me with this one. I can show you what the page looks like, okay? So in this page, you can calculate your patient's risk of having a heart attack. You can calculate the likelihood of having statin-related side effects. And it gives you also, if you look at their absent tools, there's a lot of resources for clinicians and for patients. And I actually looked at them and they're pretty reasonable. So we can use these in our clinics right here. Understanding coronary artery calcium scoring. Today, we were at a faculty meeting at UCSF, and Dr. Dobas, who's a radiologist there, was giving this quality improvement talk with, she has this new program where she is determined to read 90% of all of the CTs that are done at UCSF get noted for calcium. And so she said, we were so excited. We went from 40%, which was about what is national, of how the radiologists are reporting this, to 90% in 1 month. So the residents did great.
So what you're saying is that when there's an incidental finding of coronary calcium, it used to be that only 40% of the time did they act on it. And now you're up to 90%?
Reported in the radiology report. So when you see it, you report it. That wasn't the case. And so they put a little statement, you know, this patient may be at increased risk and may need risk management, which is a great statement. So they sent it back to the primary cares, and they're so disappointed because they sent out this questionnaire to the primary care. Did this help you? Was this something that burdened you? Do you feel comfortable with what to do with this? And the results, at least 40% of the primary care physicians said this was horrible, that they didn't want to deal with it, and you know, and this is UCSF.
They didn't know what to do with it.
They don't know what to do with it. It increases the length of time. It's another issue that wasn't the main reason why the patient is coming, so we need to change this. If you get a calcium score, my comment was, you own it. You own it. If you're the physician that you request any test, right? Like we see a lung nodule, we're not going to say, oh, lung nodule, I'm not going to deal with it, right? So that was something that I think here, the primary care can go there and press on it and have a little bit of guidance. I think we're going to get better at this. I'm going to work with, I think we can all, you know, chip in here and help primary care do the right thing, treat these patients, at least get risk stratification, right? Okay, so that's sort of, I went.
So for those people who haven't been here for the first three, to learn about why that's so important, could you just say a little bit of why do we want to know if somebody has calcification?
So calcifications correlate with or are a biological finding that shows you that there's plaque. Plaque calcifies. So it's plaque. It's showing you plaque. So basically it's people with plaque in their arteries. So they already have the biological basis, and how you think about that is going to be, are there modifiable risk factors or not?
And one of the things we had talked about is for this target population, 40 to 60-year-old people who are healthy on the outside but may not be on preventative medications, this calcium scoring seems to be an interesting way to identify those that might require statins and other preventative medications, if in the context of maybe if they have a family history but they haven't really gone further to understand what is wrong with them. So it could be really relevant for some of our patients.
Yes. So key messages for these guidelines It outlines the critical role of lifestyle intervention. That's message number 1, and I love that. Reminds clinicians of the importance of the clinician-patient risk discussion. It's not just telling the patient what to do, it involves them. That's message number 6. It reinforces the assessment of response and adherence to therapy. This is a huge deal. You cannot just give a statin, you need to follow up. You can't just give therapy and not know if the patient is taking it or not. So that's where technology comes in. This is where we can change behaviors. This is where we need to think how to do it, right? If we can get people to buy a sneaker, we can get them to take a statin, I think, you know. And other messages, specific content-driven recommendations, that's with supported evidence. So I talked about this already. So, oh, the other thing, it mentions evidence-based criteria for enhancing risk stratification, right? So there are novel markers such as ApoB, lipoprotein A, coronary artery calcium scoring. I feel this as a lipidologist and a preventive cardiology, just those are like my hidden pearls. But everybody should use these in their practice, and it just enhances the risk, right? And I'm hoping that this will lead to greater utilization of these important markers. So what about the mechanisms under atherosclerosis? Where are we thinking we can intervene to get to 0? There's been, over the years, a lot of research, and there's a lot of information about atherogenic lipoproteins, right? You measure your cholesterol, your ApoB, your lipoprotein A, triglyceride-rich lipoproteins, VLDL, they're part of the metabolic syndrome. So that's one way, or one of the mechanisms that is very well known to promote atherosclerosis. What else happens? There's inflammation. There's now good evidence that inflammation is promoting atherosclerosis. It's driving it. It's something that we might be able to target. I'll show you some data on that. And then there's a third one that is forgotten in most cases, and it's one of my passions. I work in this area. Reverse cholesterol transport for me is something that is underappreciated. So your blood vessel has a mechanism to get rid of the cholesterol that is deposited there. And that's the function of the tiny lipoprotein called pre-beta-1 HDL. And if this lipoprotein captures the cholesterol that is coming out from the artery wall, it can clean it up. And there's people who have none of these risk factors who have defective cholesterol transport. Whoops, I did something bad. Okay. Uh-oh, Brian, help. Let me tell you a little bit more about this lipoprotein. The reverse cholesterol HDL is a molecule that is remodels as it's in your blood vessel. And it remodels with oxidation. We know now that it transports these cytokines in the blood, and it can change the way that your artery gets rid of cholesterol. Okay, I'll leave it at that. Is that?
The slide before that with
Yeah. Uh-huh. Yeah, you can just keep going. There. Okay, so this is what the atherosclerosis, the ASCVD equation has. It includes age, blood pressure, cholesterol, diabetes, hypertension treatment, and HDL cholesterol levels. Now, HDL cholesterol levels not necessarily tell you how the molecule is working. So I have a collection of women who come in with early heart attacks with excellent total cholesterol to HDL ratios. And they have gotten patted in the back and said, don't worry about it, it's fine, and it's not. Okay, we are going to be learning more about these molecules. We are going to be able to tell you if your HDL has the profile that is associated with cardiovascular disease or not. And this is going to be very big data. We have in our little lab, we have the capacity to do 65 cytokines in HDL at one, and it's a huge amount of data, so we're going to need a lot of expertise in this area and help figuring this out. But it is, there are prints of health and disease, and we can differentiate these. When I tell people that I am a preventive cardiologist, usually, you know, in the world out there, people still ask me, is cholesterol really bad for you? I've read this book where, you know, it has nothing to do with it. And I just want to reassure you that it is involved. And there's more than one reason for that. And there's many risk factors that come into play, but here's like the classic graph where you see the major cardiovascular events with the LDL cholesterol reduction and also vascular deaths in relation to cholesterol reduction. So there is a very direct correlation. A lot of our prior work on preventing heart disease has been focused specifically on this, LDL cholesterol lowering, and we've spent the last 30 years doing these large-scale studies to reduce LDL with, as soon as lovastatin became commercially available in 1987. I don't know when your father was there.
I was one of the first people on it.
Yeah, 87. And then in 94, that first landmark study came out, the Scandinavian simvastatin survival study, that was the first one to show that lowering reduces the events, and since then it took off. And it has been called the single most important advance in therapeutic armamentarium against CVD. And I think that's about to change, coming soon. I hope so. I hope so in the way you'll understand why. Despite statins, and this is why I say it, approximately 60 to 70% of the events, cardiovascular events, occur in statin-treated patients. And this is what we call residual cardiovascular risk. So even though you're on a statin, you might still be having that. I don't want to create anxiety here. It's just, okay. So here is a cartoon of lipid targets. We have many drugs. I am going to focus on the newer ones, which are the PCSK9 inhibitors and the ezetimibe, which are two drugs that we are using currently in our clinics and have been very effective. So thinking about these lipid targets again, ezetimibe to reduce cholesterol. The initial study was done in people with kidney disease, and we showed that there was a risk reduction of 17% of non-fatal MI, coronary death, non-hemorrhagic stroke, and arterial revascularization with simvastatin plus ezetimibe. There was no reduction in mortality, and the beneficial effects in reducing major cardiovascular events, like we said, it was safe in renal impairment, and this calculation of the NNT was done by our pharmacist, Crystal Shao, who couldn't be here. She was going to present this part. So she calculated the number needed to treat 4 people with renal disease on Simba plus ezetimibe, 48 over a median of 4.9 years. That's pretty good.